Welcome to The Explainer. Today we are diving deep into a powerhouse antidysrhythmic drug that, honestly, you gotta know inside and out. We're talking about procainamide.
So picture this. You're in a high-stakes situation. Your patient's heart is going haywire. A clear plan isn't just nice to have, it's everything. Our whole goal with this explainer is to build that plan together so you can reach for this drug and use it with total confidence when the clock is ticking.
All right, so here's our game plan. We'll kick things off with how it works, then we'll get into a simple green light, red light system for when to use it and when to absolutely not. After that, we'll talk risks, nail down the dosing, and wrap up with some really key clinical pearls.
Okay, first up, the heart's rhythm regulator. Let's get right down to basics. What is this stuff and how does it actually work?
So yeah, the slide gives you the textbook definition, right? But what does that actually mean? Let's break it down. I want you to think of procainamide as a kind of rhythm gatekeeper. It steps in and tells those chaotic, rogue electrical signals in the heart to just take a breath. It calms everything down, slows the conduction, and shuts down those dangerous rhythms firing off from where they shouldn't be.
Now, this timeline, this is super important for you at the bedside. You're not waiting forever. You're going to start seeing this drug work in about 10 to 30 minutes. It's going to hit its peak power within an hour. Knowing this is huge because it helps you know what to expect and what your next move should be. All right, next section, green light, when to use. So let's talk about the scenarios where you say, yep, this is the right tool for the job.
Okay, so where does this drug really shine?
Well, you're looking at stable monomorphic VTAC if the QT interval is normal. That's a big one. Also, reentry SVT that's just not budging with your other go-to treatments. It's also a fantastic choice for a stable, wide complex tachycardia when you're not totally sure what the origin is. And then there's this really specific, really important one, AFib in a patient with WPW. And trust me, we're going to come back to that one because it's a big deal.
Okay, just as important as knowing when to go is knowing when to hit the brakes. Let's talk about the red lights, when you do not use this drug.
And look, this list is non-negotiable. These are hard stops. If your patient has a second or third degree block and no pacemaker, nope. A history of torsades or a long QT interval to begin with, absolutely not. And you definitely don't want to give it if you suspect digitalis or TCA toxicity. Giving procainamide in these situations, well, it's like pouring gasoline on a fire. You can take a bad situation and make it catastrophically worse. All right, so let's say we've got a green light. We're moving forward. But that doesn't mean we can relax. This is a powerful drug, and with power comes risks. We've got to be aware of the side effects. So here's the big one, the one you really have to watch for. This drug does two major things that can cause trouble. First, it's a vasodilator, meaning it relaxes and widens blood vessels. Second, it has a negative inotropic effect, which is a fancy way of saying it can make the heart pump a little weaker. You put those two together, you can get a serious drop in blood pressure. And that's especially dangerous if your patient's heart function is already compromised. And that drop in blood pressure is just the start. This list is exactly why your eyes need to be glued to that cardiac monitor. Look at these: hypotension, bradycardia, AV blocks, even the things we expect to see, like a wider QRS or a longer QT, well, there's a fine line, right? It's a spectrum. And if you cross that line, your therapeutic effect turns toxic, and you could actually kick off a worse rhythm, like VT, VF, or even a systole. And we're not done with the risks yet. You also have to be thinking about drug interactions. A quick heads up, it can make skeletal muscle relaxants more potent. And on the flip side, some really common drugs, we're talking cimetidine, beta blockers, amiodarone, can actually cause procainamide levels to build up in the body. That means a higher risk of toxicity. So what's the takeaway? You guessed it. Always, always check the patient's full med list. Okay, on to the practical stuff, the dosing protocol. Let's get into the nitty-gritty of how to give this drug safely and effectively. I want you to burn this slide into your brain. This isn't just a guide, it's your set of hard and fast stop signs for the loading dose. You start the infusion at 20 to 50 milligrams per minute, and you keep going until the rhythm converts. But, and this is a big but, you have to be ready to stop on a dime. You stop if the patient gets hypotensive, you stop if that QRS widens by more than half of what it was originally, and you stop once you hit that total dose of 17 milligrams per kilogram. Any of those things happen, the infusion is over. So here are the numbers all in one place. For adults, after that loading dose we just talked about, you're usually going to switch over to a maintenance infusion, somewhere in the 1 to 4 milligram per minute range. And I have to make a really important point about the pediatric dose. As you can see, it's a different protocol entirely. This is one of those times where you absolutely need to get an expert consultation.
Okay, last section. Let's talk about some expert clinical pearls. This is the stuff that goes beyond the basics, the little details that can make a huge difference in patient care. Okay, we mentioned this earlier, but it's so important it gets its own slide. This is a huge, huge takeaway. If you have a patient with WPW who goes into AFib, your instinct might be to reach for something like amiodarone. Don't. Amiodarone can actually block the normal pathway and funnel all those chaotic atrial beads down the accessory pathway, which can lead to a dangerously fast ventricular rate, even VFib. Procainamide, on the other hand, actually works on that accessory pathway. It blocks it. That's why in this very specific but very scary situation, Procainamide is your go-to.
And great patient care is all about looking at the whole picture, right? Not just the ECG. You've got to be thinking about these other factors. For example, pushing this drug too fast can cause severe hypotension. If your patient has renal or cardiac dysfunction, you're likely going to need to reduce the dose. You need to be extra cautious in patients with a history of asthma or recent MI. And what about pregnancy? Well, you can use it for an acute SVT, but you want to avoid long-term therapy.
And all of this brings us back to what is, without a doubt, the golden rule. Look, if you forget everything else from this explainer, please remember this. You have to be watching. Constant, vigilant monitoring of vital signs and the ECG isn't just a good idea, it is absolutely 100% non-negotiable. So as we wrap up, I'll leave you with this question to think about. You've got the protocol down now, but when things get chaotic and the pressure is on, which of those red lights is going to pop into your head first? Really taking a moment to cement those contraindications in your mind, torsades, the high-degree blocks, the long QT, that's what's going to make sure you use this incredibly powerful tool, not just well, but most importantly, safely.